personal level as I get my COVID-19 vaccination. I'm up, it's my turn. I am involved in the care of patients still. I see patients in our ambulatory practice as well as do inpatient rounding. And based upon the way we've been doing the vaccination, all our frontline folks like Hawkeye, who's much more frontline than I am, and the ICU doctors, and the floor folks, and the nursing staff, and the environmental services staff, directly involved in the care of COVID-19 patients have been vaccinated, and now it's my turn. So we're going to get to see me on the air with my T-shirt on, Hawkeye. It won't be quite as cool as what you do, but I'm going to rock it today. I got an outdoor vest to show you, Mr. Outdoor guy. I should have worn my fly fishing vest. One of our great team members here said, "Hey, how come you didn't bring your fly fishing?" If I thought about that, I would have done that. That would have been really cool.
Second dose.
I know, second dose. That's a great point. I will do just that. All right, so we have a pretty cool program to start with today, though. Kevin Alt, who is an OBGYN physician here at our health system and a member of the CDC Advisory Committee for Immunization Practices, is joining us, along with Dr. Angela Myers, who's been with us before. Welcome back. The Division Director of Infectious Disease at Children's Mercy Hospital. We're going to talk about vaccines and update the story today about the multisystem inflammatory syndrome being seen in children. But first, Hawkeye, it's a new year. How are we doing?
You know, a year ago, we were kind of just hearing the rumblings about really what was going on, you know, across the ocean, and now look where we're at. Currently, you know, last week we had pretty good numbers. We were down to actually 52 acute infections.
And we were that was pretty cool.
I was pretty happy.
Yeah.
Since that time, though, I would say we are less happy, less optimistic. The numbers have gone up. We have 70 acute infections right now, with 28 in the ICU and 15 of those on the vent, so a pretty high proportion on the vent. We still have 56 people in that kind of recovery phase, with 7 of those that are remaining on the vent as well. You know, luckily Hayes, as far as, because we understand their capacity, their numbers are down. They have 23 infections with 16 active and 7 in that recovery period. But here for our increases, like it has been from 52, you know, at their recent low to 70 now, that's kind of concerning.
Are we concerned that that is a post-Christmas? Are we beginning to see the surge?
I think it's somewhere in between Thanksgiving and Christmas. Yeah, you know, certainly I was working at the end of the week last week on New Year's Eve day and New Year's Day, and actually did see a patient who was at a Christmas gathering with people, with a bunch of family, you know, probably 15 to 20 people. Everybody felt fine, but a couple days later, somebody got COVID, and so now this patient is in the hospital because of that gathering. So we know it's happening, it's going on out there. We know that you can have the disease and spread it without knowing that you have symptoms, 1 to 2 days before symptoms at least. But even in those otherwise who are totally asymptomatic patients, you can spread the disease, and this is what happens.
Yeah, and that's a big deal. And so everybody just needs to remember, please try not to gather in those groups. Make sure you keep wearing the mask. Even as we get vaccination, your defensive strategy is as important as your offensive strategy. It's a team game. If we're going to win, we got to play both sides of the ball here. Well, I think I'm ready for my COVID-19 vaccine. So I'm going to introduce through James, but first I have to put my mask on. So I've got my Mask Up KU right here. Put my mask on because we want to be safe as we officially do this. Tu is one of our outstanding assistant nursing directors, and Hawk and I wanted to get our shots during the update to literally show you what to expect so that you'll answer your call to arms. So I'm going to take my coat off here and get ready. Oh, wait a minute. Here we go. I knew I was going to do this. Just 1 second. Hawk, I talk about the numbers for a minute while I get confused with my mask and my earpiece.
Yeah, you know, we were certainly happy. You know, we understand that in holiday or special occasions, that the surges aren't 2 weeks later or 3 weeks later. We saw that with the original surging after the shutdown or the stay-at-home orders, and that was with Memorial Day. After that, it didn't happen in 2 weeks or 3 weeks, but it was 4, 5, 6 weeks down the road, because it does have to get to those second and third line of infections. Plus, it does take time to get to that point where you need to be hospitalized. Some people are hospitalized in the acute setting because they have fever and just feel bad. But it's really that 10, 12, 14 days after the initial infection when you have that inflammatory response that is going on that causes a lot of those lung infiltrates, that pneumonia that you may see from COVID, and the lack of getting adequate oxygen to your tissues when people are coming to the hospital. And then, of course, we know that deaths can lag behind hospitalizations by even 2 weeks as well. So we are just seeing a lag. It's nothing that we're going to know 1 or 2 days afterward. It is a week process, week by week. And the only way we can really know is by looking back retrospectively on what the full impact of that was.
Yeah, so important. Okay, well, here we go. I'm about ready to get my shot here in the air. Now, too, I do have a question for you.
Yes.
You and I have known each other for a long time, right?
Yes.
Yes, and we're not going to tell everybody how long. But there's no vendetta here, right? This is just, you're not out to give me.
Not at all.
Okay, awesome.
It's my pleasure.
All right. Yeah, pleasure. That's what I'm
Right.
Let's do it.
All right, Dr. Stites, you don't feel sick at all today, do you?
I don't.
Okay, do you have any allergic reaction in the past to
No,
any
ma'am, I have
vaccination?
not.
Okay.
I'm actually
going-
pretty excited to get this vaccine.
Great.
Yeah.
I'm going to be giving you Moderna today.
Okay.
So please keep this card in a
I'll
safe
keep that with
place
me,
and
yeah.
bring it with you for your second dose.
Thank you, and that's 4 weeks away from now.
That is correct.
All right, there you go.
Yep, and I think we should be getting our second dose of Pfizer this week, so we will start giving it to our employees that had their
That's
first
right, we
dose.
are on our second doses of Pfizer already, so there you go. Here it is, folks. And just to say, I'm 60 years old. I do have a couple of risk factors around this, but the way we did this, it's my turn just based upon our system of moving through all practices of people who are seeing patients. So I think that's our approach.
You ready?
Yes, ma'am, I'm ready. Let's do it.
And as soon as we are able to give it to our other final employees and our patients and start vaccinating the public, we are going to be able to do that.
Yeah, that's exciting.
We're
There you
working on
go.
it.
Thank you, ma'am. I appreciate that. Yeah.
We'll schedule for your appointment
All right.
around February.
We've got our call to arms. There we go.
That's
You
right.
had your arm. I got my arm. We got a lot more arms. to go with that,
Exactly,
don't we?
exactly.
That's
My
awesome.
arm is still here. It didn't fall off.
It
so.
did. You haven't passed out yet,
I haven't.
as far as I know.
She also didn't give you a warning on a stick and a poke either.
Oh, she did. She said, "Are you
Oh.
ready?"
Yeah.
So I knew that was coming. All right. So we can take our masks off now. So we're going to take those off. I'm going to pull this out of my ear again. All right, so there's a 15-minute observation period, and that's done because this is a relatively new vaccine, Hawk, and we need to make sure that people are okay after they get the vaccine, right?
Yep, absolutely. And we know that these monitoring periods are nothing new. We do it with shingles vaccine. We do it with HPV vaccine. So it's just part of standard protocol, not for every vaccine, but certainly for some, and especially with this because it is so new.
All right, well, let's see, before we go any further, too, I know we have to wait 15 minutes, and you have to come back and check on me.
Yes.
But before that, let's see if there are any reporter questions out there.
Happy New Year, Cody Holyoke from Channel 9.
Cody.
Hi, Cody.
How are you guys? We saw the headlines overnight about the U.S. looking at the Moderna vaccine and saying, hey, we might be able to do half the dose to try to spread out the supply. I was curious about your thoughts on this, and you're much more read up on it than we are. Did the studies, the trials look at that possibility?
You know, we've got a couple of experts. So first, let me turn to Hawkeye, and then we're going to introduce our panel a little more,
Yeah.
because we've got to ask them to pull them into that question. Go ahead, Hawk.
You know, I'm not privy to that information. We know that they did look at different doses. They have those out there on the FDA briefs, and they looked at those doses in those initial studies to see what the response was. So I'll start there and then let our experts talk.
Dr. Alt, you were on the Cdc Advisory Panel. Talk to us a little bit about that and what your thoughts are on the half dose.
Well, I'll just expand on what Dr. Hawkinson just said. The phase 1 and the phase 2 studies are usually dose-finding exercises, and so there were different doses, but the emergency use authorization and the ACIP recommendations, the committee that you mentioned that I'm on, are based on the phase 3 data, which was fixed dose versus placebo. You know, there's been a lot of talk about reduced dosing and one dose and that kind of thing. You know, speaking for myself, I think that makes me a little nervous because we don't have data about that. You know, there are 14 of us on the ACIP, and there's a lot of different backgrounds, plus there's a couple of dozen liaisons, and this would be the kind of issue we would talk out, and we didn't really talk about this because the last time we met 2 weeks ago, not sure people were thinking about this that much. So, you know, it makes me a little nervous, and I would like to see some data, basically.
Yeah, I would think that's exactly right. Dr. Myers, any other thoughts around that as well?
No, I agree with what's been said so far. What we know is that there is an antibody response to the first dose of vaccine, but the best antibody response comes after the second dose. And so I agree that we really don't know what would happen if we immunized everybody with one dose and delayed that second dose.
You know, the other thought, I read that as well, and I didn't really dig into the Moderna data, although it was published recently in the New England Journal of Medicine. It came out on December 31st, just to say if anybody really wanted to go see it, you can. It's free and open to the public. But and a good article to read. But the other thought is, right now, our problem isn't number of doses. We're still lagging behind getting the doses into arms. So we really need to work on our logistics aspect as well as thinking about having the dose. Thoughts about that?
You know, I totally agree. I think initially here we had our systems in place, but it takes a little bit to ramp up. We are, I think, running pretty efficiently now at the ability to get a large number of employees vaccinated. And like I said, we are working now on those systems for mass vaccinations for the public when they are available to the public as well. So we've kind of moved out that. We have, I think, really good protocols and systems in place for our employees in general. But it is going to be, the key is really getting access for the general population for those vaccines.
Yeah, and it is to say, it's been an outstanding partnership between the health system and university, because the health system is going to do some mass immunization clinics. We're going to do them over in the university, and because they have some space in the new health education building. So I think that's going to be a great partnership and help us to get a lot of people vaccinated, beginning with our own teams here and moving on to healthcare workers and first responders before we move down the list and things. So I think we're excited about that opportunity. Questions, other questions out there?
Yeah, this is Brian.
This is Ellen McNamara from KCTV5. Happy New Year, everybody.
Happy New Year, Ellen.
Happy New Year.
Yeah, so you actually kind of touched a little bit. That's going to lead me into my question. And we reported last week that the state of Kansas is dead last in the country right now for getting the vaccine out into people's arms. And so Senator Romney had blasted the government over the holidays and said that part of the problem is the United States is asking health systems that, are so overwhelmed right now to tackle the job of getting the vaccine out. And he had suggested that maybe even veterinarians, medical students, so you were talking about medical schools, get involved in distribution. Is there anything so first off, does it surprise you that Kansas is dead last right now in the country? And then is there anything just that you think could possibly be done to get this out into more arms across the state?
Yeah, that's a great question, and one that's perhaps a little bit out of some of our pathways, because we don't usually take on some of that. But let's say this about it. The first thing we have to do, and I think the ramp up is going to be a little slow as we get the full system in place. What will help all immunization centers is to know how much vaccine you're going to get, the date and the schedule you're going to get it, so you can plan and scale up for that. But make no mistake, this will take all of us to do that, whether it's the CVS and Walgreens pharmacies, which, by the way, remember what they've done in nursing homes, whether it's your primary care office, whether it's hospitals and health systems. We need to put as much out there as we can, because we have to have a call to arms. If we are going to be able to tackle this novel coronavirus effectively, it will require a call to arms. And I mean that both in the figurative and the literal sense, because that's what's going to help us get the vaccine into people and get it in their arms so we can get people protected. But I think it's just taking us a while to get through those logistics in order to know how much we're going to have, when we're going to have it, and then understanding exactly who we want to give it to, Hawkeye.
Yeah, I think, again, we want to definitely stay with what we're, in our lane with the medical aspect of it. I think it does take time. I think some of that also is the ability to have it in the cold storage initially for Pfizer. I mean, there are just little missteps, but I think overall it is getting better, and it should continue to get better. And we also are working with our partners out west in western Kansas to help get them that as well. So there is a lot of help, but I think it does take time. But I think it has improved since day one, and will continue to improve as well.
Yeah, and I think one of the challenges, Kansas is such a rural state. You have a lot of territory to cover, and you also have, I think, a situation in which I think in 2 weeks will look a lot different than we do right now. Dr. Alls or Dr. Myers, any other thought about that?
Well, we talked about this quite a bit at the ACIP meeting that was the weekend before the holidays. This 17th and 18th, I believe, were the dates. And there were some very impassioned pleas from the public health people. I remember Jeff Dushin in particular as a public health official for Kings County in Washington, said we put a lot of money into developing the vaccine. We put very little money in figuring out how to deliver the vaccine. And so, that's where the bottleneck is. As you said, however, we've not really tried anything like this in American history. A couple of times I've mentioned the polio campaigns in the mid-1950s. I remember getting the sugar cube, the oral polio vaccine in elementary school, and I think you might too. So it was an entirely different audience back then. So, having a group of school kids that are all in school at one time, we went to the gym to get it, is a lot different than what we're trying to do now.
Yeah, McCoy Elementary School, Independence, Missouri, remember it well. Yes, indeed, out in the gym or in the classroom, getting the polio vaccine on a sugar cube. But this is a little different in the arm. But I think it is just going to take, I think the point of, gosh, we've put all this thing into warp speed with trying to develop the vaccine. Now we're really going to have to focus on logistics of getting the vaccine. And, the evidence is what the evidence is. We haven't gotten as much in as we need to, but we're going to get there.
But that wouldn't be inconsistent with what has been observed for the past year, which is a very little infrastructure to the public health. I mean, that is one of the other things that has been exposed this past year is the infrastructure in general, and specifically the infrastructure for public health as well. So hopefully this is another call to arms for that. And recognizing and exposing that, and then making changes moving forward.
Yeah, I think we have to learn from this event and understand that our ability to affect public health and to deliver that for things like this is something we need to work on as a country in order to make sure we protect each other well. So, other questions? Okay, not hearing any. Let me first turn to Kevin Ault, to Dr. Ault. So thoughts about things, about how we're doing overall and where you see things going and your work with the CDC Advisory Committee.
Well, I was watching the news this morning, and the data that was being shown on Good Morning America was that we had 4 million doses given out so far. The goal for Operation Warp Speed was 20 million by the end of the year, so we obviously missed that. There are some other vaccines on the horizon, and some of them are being used internationally. So as far as supply goes, crystal balls have been in short supply for the last 12 months. But as far as supply goes, you would think it would be better over the next few months, especially if we get more different types of vaccines available with different handling characteristics and might be able to be given in doctors' offices and that type of thing. So yeah, it's going to be very hard to predict the future. I usually start off by saying, about 50% of what I say about COVID is going to be wrong, maybe even in a week. And so, but as far as what's going on in the big picture, it looks like the supply will loosen up considerably these first few months of this new year.
Yeah, what do you think of the future of the AstraZeneca vaccine in the United States? Any insight about that?
Well, they still have to go through all the processes at the FDA, and it seems like the timing has been, the company announces that we're ready to submit to the FDA. A week or two goes by, the FDA works triple overtime and has a public hearing, and then we have an emergency ACIP meeting. The FDA is the person that issues the emergency use authorization, then the Advisory Committee on Immunization Practices comes in and makes some clinical recommendations. So, that we will probably have more safety data on that vaccine because it is being used in the United Kingdom and some other places. So yeah, I mean, more vaccine would definitely help the crunch we're having. I think last time we talked, there are 20 million healthcare workers, 3 million people in long-term care facilities, and then 100 million essential workers. That's a lot. That's a lot of vaccine. That's half of the, 2/3 or 1/3 of the country, basically, in that first phase one.
Yeah, it's so important. So talk to us a little bit. One of the questions we get on the program a lot, Dr. Ault, and we're happy you're here today to help us answer this, is what about expectant moms? Should they be getting the vaccine? Is it safe to breastfeed after the vaccine? How does that look?
Well, let's separate pregnancy and breastfeeding, and our other colleague from Children's can help with the breastfeeding question a little bit. It's hard to imagine a mechanism where a vaccine goes in the arm and causes harm to a newborn. There's lipases and RNA breakdown enzymes and, in the arm, in the maternal circulation, the breast, and the child's stomach. So I'm not that worried about breastfeeding mothers. I think the only thing, if anybody's listening in who is breastfeeding, if you get a fever or another reaction, your breast milk supply might be down for a day or two. But that group, I'm not that worried about. And I think we had a consensus when we talked about this at ACIP. For pregnancy, of course, we don't really have a lot of data. We have a few people that got pregnant during the trials of the 2 vaccines. They're available for emergency use authorization. So we're very handicapped as far as what to tell people. There's not an a priori reason to think a vaccine that's not a live virus would cause problems during pregnancy. The real problem we have out of those 20 million healthcare workers is about 330,000 are going to be pregnant or breastfeeding, and many of them are frontline providers, healthcare workers. And so, and pregnancy is at risk for more severe disease. So what ACIP and the American College of Obstetricians and Gynecologists have recommended is to realize there's not much data. Talk to your obstetrician, try to evaluate what's going on in your community, and try to see what your own exposure is. So several factors go into that decision. We might have data pretty quickly because of the VSafe program. Our next regularly scheduled ACIP meeting is in February. The VSafe is a CDC vaccine safety program, and you're going to get a text later today to sign up for that, I hope, if you didn't sign up right there live while I was talking.
I will be signing up.
Okay,
Yep.
so yeah, I mean, that's 500 pregnant women signed up the very first week for that program. So, that's 20 times what we were in the trials. So yeah, we should have data relatively quickly, and hopefully there'll be no problems.
And to be clear, I'm not pregnant, so I won't be able to participate in that part of it, but I can certainly participate in the other parts of it. So hey, listen, have we had moms who are COVID positive to deliver at the hospital? How have they done? How are the babies doing?
We seem to have lots of those moms. Yes, that's why I was first in line for the vaccine ahead of you guys. I got mine 2 weeks ago. I would guess 10 or 20%. There's a registry that we're sending, our cases to at the University of California. Most people do fine. I mean, pregnant women, one of the nice things about being an obstetrician is pregnant women are young and healthy and usually tolerate, pneumonia and heart disease and those kind of things during pregnancy relatively well. However, locally and nationally, we've seen some very severe cases, and there have been several on the 6th floor, of our hospital that have been very ill, some transfers. So, I'm just surprised we screen everybody when they come to labor delivery, and I would guess we're running about 10 or 20%, positive rate. I haven't been on labor delivery since before the holidays, so I don't know if it's gone up or down, but that's kind of been my impression for the last month.
All right. Well, I think my time's up. I think I'm going to have my follow-up with James. How am I doing so far?
You look great. How do you feel?
I feel good.
Okay.
Yeah.
And have you?
I got to have my signature right here. All
Yes.
right.
Hey, could you go around on the other side
Oh.
of the camera?
Oh, wait a minute.
Okay.
I have to put a mask on. I forgot. Wait a second. Time out. Oh, my gosh. I can't believe I did that. There we go. Okay.
Okay.
My mask is back on.
Great.
Yep. I've got my signature. I feel good.
Wonderful.
My arm hasn't fallen off yet. I'm not sure. I don't think he really stabbed me or anything. That's good.
Okay, so your next appointment will be
Yes, ma'am.
around February the 1st. And
Okay.
then we'll get a date and a time for you.
All right.
All right?
Hey, thanks for
All
coming
right.
down. I
Thank
appreciate you
you.
being here.
We'll see
Appreciate
ya.
all the great work you've done at
Thanks.
KU for so many years, too. Thank you
Thank
very
you.
much. You guys don't know, Sue's been one of our best nurse managers on the floor. She worked with oncology. She works in the cancer program. We turn to her a lot, and today she's even given shots, so thank you.
Thank you.
All right, so now we're going to turn to Dr. Angela Myers. Angela, man, more community spread out there, and I've heard before that you guys are seeing some more of the multisystem inflammatory syndrome in kids. How are things at Children's? How are things going?
Yeah, we are seeing more multi-system inflammatory syndrome in kids. It really does mirror what the CDC is reporting, what's happening nationwide. We saw an increase in COVID cases starting around Halloween through November and through Thanksgiving and even into December, which makes sense that there would then be a resultant increase in MIS-C because it generally occurs 2 to 4 weeks after having had COVID infection.
Go back on, so you have to talk longer. So I'm back, and you gave a great answer though. So at Children's, what concerns you most about the syndrome, and does it generally go away? What kind of therapies do you use for it?
Well, there's really no long-term data, and the therapies that we use include immunoglobulins and steroids, and then sometimes immune modulating agents like anakinra. A multi-specialty team is always involved with all of these kids, including rheumatology and infectious diseases and cardiology, the ICU doctors if the patient is sick enough to be in the ICU, and the hospital medicine doctors if the patient is, well enough to be on the floor. So it's a multidisciplinary team that really kind of makes decisions in real time what to do for each individual patient. And there's data being collected. There are 3 different studies ongoing at Children's Mercy collecting data on these kids. One is a long-term cardiac outcome study where we're participating in a national registry of MIS-C. And we're just now getting started on another program that will compare diagnosis and management of children with COVID-19, so acute COVID-19 infection versus Kawasaki disease versus MIS-C. And, there's some overlap between Kawasaki and MIS-C. And so this particular study will be really good to help us look at that and understand the differences a little bit better and what the best diagnostic methods and treatment methods will be moving forward.
So important. Are you seeing a lot of heart and lung complications long-term in kids so far, or what we would construe to be long-term, since I guess it's only been a few months really, but what do you think about that?
Yeah, we've not seen a lot of long-term heart complications. We have seen some coronary artery dilations and even some aneurysms that will continue to be followed long-term. But for the most part, kids recover from their MIS-C and do pretty well.
Have we had any deaths in kids from COVID-19 or from MIS-C?
We have not, but there have been nationally. So there's been, as of December 4th, the CDC reported around 1,300 cases with 30 deaths. Their data will be updated this Friday. It's updated the first Friday of the month, so it'll be interesting to see what's happened. If what's happening nationally is what we've been seeing here in Kansas City with an increase in cases over the last month or so, and we'll have a little bit more information from that.
Okay, so schools are probably going to start going back pretty soon. What are your thoughts about the safety of schools and the safety of kids at schools and the safety of the families who have the kids at school? Talk to us a little bit about that. You guys have been intimately involved with school districts and have done a great job working so hard with them.
Well, thank you. I'm glad you asked me that. A new paper came out in the MMWR in mid-December, and it was a case control study that was conducted in Mississippi with the Mississippi Department of Health. And they followed 400 kids, one-third cases, one-third controls from acute COVID infection. And they looked at a number of different things. And what they found was that primarily the kids who were infected from COVID were related to gatherings, weddings, funerals, parties, play dates, things like that, but not related to being in school. When schools were using appropriate PPE, or masks, when schools were using the appropriate protections, right? Distancing and masks. And so that data is really helpful. So kids who went to gatherings, who were doing play dates, who were doing big social events, they were 2 to 3 times as likely to get COVID than kids who were not doing those, than kids who did not have COVID infection. But they did not see an increase in COVID infection because of attending school or child care centers. So I think that data really helps us to understand that transmission really isn't happening in schools. There's another study from the UK that found the very same thing. They are also not seeing transmission in schools when the schools are taking appropriate measures.
So the rules of infection control travel with you wherever you go, whether you're at work, whether you're in school. We saw the same thing at KU, right? I mean, the infection rate at KU was actually lower than it was in the community because the kids were distancing, doing the things they were supposed to do. And I think it just makes, again, it makes all the difference. If you follow the rules, you can stay safe. When you don't follow the rules is when danger comes aboard. Okay, well, thank you for that. And I so appreciate the great work you guys have done. We hear from a lot of our county folks and both sides of the state line. We know Children's have been intimately involved with a lot of the school districts. So thanks so much for doing that great work. All right, Jill, let's see what questions are out there.
Oh, my goodness.
I bet there are a few.
Yes, all right. We're going to start with Cindy because it's kind of on topic. She has a 2-part question. One of them is, that the newborns that are born to moms that are COVID positive, are those newborns tested and do they have COVID? And the second question is, in light of Joe Ellen Engelbart, who was the Jackson County prosecutor who died over the weekend of COVID-related after giving birth, how is that impacting the advice that Dr. Alt is giving his moms that might be thinking about birth plans and that kind of thing? Should you conceive during a pandemic?
Should you conceive during a pandemic? Okay, Dr. Alt, I'm going to start with you. We're going to let every one of our panelists swing at that one, because that's sort of, I mean, that's just a great question, well framed, and has a lot of personal issues associated with that because of what's just happened.
Yeah, I mean, you just said infection control follows you everywhere. That's certainly the advice we're giving to pregnant women. As far as the risk of pulmonary complications in pregnancy, we know with influenza that it's the last 2 or 3 months of pregnancy, the third trimester and the first few months postpartum are the most vulnerable time. So when the heart is really stressed in late pregnancy, heart and lungs, and before it can get back to normal, the first few weeks postpartum, we know that from influenza data, and we've known that for a long time. Whatever you can do as far as social isolation, distancing, getting your flu shot while you're pregnant to avoid other respiratory infections are all things that we tell our patients to do. As far as conceiving during a pandemic, we get that question pretty frequently. Some of the data would say that women with underlying health conditions like hypertension and obesity are most at risk, and we would like those women to come in anyway for a preconception visit. So yes, that's something you should be discussing with your obstetrician and something you should think about. So maybe I should let Dr. Myers, I started to ask Dr. Myers a question during the last session. Maybe I should let her talk about newborns, but I have not seen newborns, any data that indicates newborns get ill from COVID. So most hospitals that I know of aren't isolating babies from their mothers for the obvious benefit that babies get the first few days of life from being with their mothers.
Yeah, thoughts about that? I know we started that way. When we first started the pandemic, we didn't know. I think we've relaxed all that, Dr. Myers. So thoughts about the risk to baby from a COVID-positive mom?
Yeah, we have not had any infections occurring either congenitally or postnatally from infected moms in our NICU or our nurseries. So I wouldn't, obviously moms need to continue to practice infection control and wash hands and wear a mask when holding their brand new baby. But they should certainly be around their baby, hold their baby, breastfeed their baby. That we know that breast milk is best for babies, and that bonding is incredibly important.
Hawk, thoughts that you have as well?
No, that was all well said.
Said it well?
Yeah.
Yeah. All right. Next question.
Yeah, Jeannie says, some of our friends have had COVID. They say now they can't give COVID to anyone. They can't get it. Don't need to wear a mask or social distance. Are my friends right?
I would say the answer to that is you flunked. Hawk?
Correct. No, that is not correct. That is not right. Your friends are not right. Even after having COVID, there is a 90-day window when you may be immune from getting it again, but that doesn't necessarily mean you're immune from giving it to other people. And we have seen well-documented cases of reinfection at 60 days, in that 60 to 90-day window as well. And remember now, there is a lot more information about that new variant that has been found in different countries, which possibly can be anywhere from 10 to 20 to up to 70% more transmissible. Again, we are still waiting for a lot of data on that. Clinically, it doesn't look that it has changed the severity of the disease, but if it is more transmissible, that's what makes following all those pillars ever more important, and that is masking, distancing, not meeting in large gatherings. If we're talking about schools, then it's de-densifying as well. So you have to continue to do all those things that we have been talking about.
The pillars of infection control follow you wherever you go. Whether you've had COVID or not doesn't mean that you can relax, because you still don't want to infect others. And the idea that you can't transmit it to others is not founded in science. It's founded in the internet. Dangerous place to start making medical decisions from.
Myth-busting continues with Linda.
All right.
Two-parters. One, I heard over the weekend that vaccine alters your DNA. I also heard that it's made from fetal material,
Oh,
tissue.
we keep getting this fetal question. Okay, well, Dr. Alt, does the vaccine alter your DNA?
No and no are the answers to those questions. So I think last time I was on, I said I need one of the first or second year medical students to follow me around and remind me of these pathways. But you go from DNA to messenger RNA to protein. You know, retroviruses go backwards, but humans aren't retroviruses. So I think it's the simplest way. We don't have the mechanism to go from RNA to DNA in our genome. And no, the RNA that's in the vaccine is manufactured. It's chemically made bases, and that, again, that's chemistry that I learned a long time ago and maybe have forgotten a lot of, but you know, ask your friendly neighborhood medical student or college student that's taking biology for that information.
Dr. Myers, from your standpoint, any fetal tissue lurking around in those vaccines?
No, there's no fetal tissue in these vaccines. In fact, the vaccines have very little in them at all. They've got a lipid nanolayer and the mRNA that Dr. Alt was referring to, which, by the way, doesn't even go into the nucleus of the cell. It stays in the cytoplasm, makes the protein, and then gets broken down. So there's no possible way it can get incorporated into your DNA or alter your DNA in any way.
Just so our audience knows that the DNA sits inside the nucleus of the cell, and then the machinery of making the cell work sits in what's called the cytoplasm, which surrounds that nucleus, and then there's a membrane to keep it all together that goes around the cell. In this case, which I think we're saying is that the vaccine pieces, Hawk, get into that part of the cell where the machinery sits, but never gets into the brain of the cell, the nucleus.
Yeah, correct. This modified RNA gets into the cytoplasm of the cell because of its uptake after the injection, but it does not make it into the nucleus. And again, the nucleus is where the DNA, the chromosomes are. There's no incorporation into your DNA or chromosomes. There's no microchips. Some of the cell lines initially, when doing the experiments and working on these vaccines, were from some aborted fetal tissue. But we have seen that there have been statements from the U.S. Conference of Catholic Bishops and the Vatican itself saying you are so far removed from that. You are not contributing to that crime or that action. You should take the vaccine if you are otherwise able to get the vaccine. So you shouldn't have a moral code against getting it for that reason. And as far as safety, just as Dr. Meyer said, it's fully safe as far as that aspect goes as well.
Jerry is retired from KU. He's 65 years old.
Hi, Jerry. Thanks for working here. Thanks for being a part of KU.
Yeah. And he's had some circumstances in his family, and his son now needs a ride back and forth to work. And he wants to know, is that safe for him to do that?
Yeah, that's a great question, Hawkeye. What do you think?
I think it's all about risk reduction and mitigation. It's never going to be elimination, but there are things you can do to help reduce that.
Wear a mask. Maybe open the window a little bit, even in cold weather, to help add a little more circulation, and make sure the driver has a mask.
Yeah, understand how long that drive is. I think if both parties are wearing masks, you could even maybe throw in a face shield or eye protection with goggles as well. Those are all things to reduce mitigation. And we can always go back to that MMWR report about the two hairstylists in Springfield and all of the patients or clients that they were able to interview. They did not find any link from those hairstylists to any of those clients for spreading or transmitting the disease. So if you can do that, you can reduce your risk. Won't fully eliminate it, but certainly reduce it and hopefully give you a little bit better feeling of safety.
Marcia said that she heard on the national news that asymptomatic people that are COVID positive cannot spread the virus. Is that true?
What national news did you listen to? Because that is utterly untrue.
Yeah, that has been untrue since pretty early in the spring, I believe. That was one of the concerns and one of the reasons why this is so transmissible compared to SARS-CoV-1 or the original SARS, which you really weren't able to infect other people until 5 to 7 days after symptoms. So it was easy to isolate those people and contact trace. This is so much more difficult because, number one, of the level of asymptomatic or pre-symptomatic people and the fact that you can spread this disease 1, if not 2 days before any symptoms really peaks out, and then 1 to 2 days after is when it's starts to become less transmissible, probably until about that 7 or 8 day mark. So certainly any pre-symptomatic or asymptomatic people absolutely have the ability to spread this disease.
Dr. Myers, children who are asymptomatic, can they spread the disease, and can children spread the disease in general?
Yeah, that's a good question. So yes, children can spread the disease, but what the data has shown thus far is that younger children are less likely to spread it than older children, and that older children, adolescents, tend to be more similar to adults' ability to spread disease. But like most respiratory viruses, it can be spread before you have symptoms.
And Dr. Alt, I know you know a lot about vaccination in general. Where are we getting this idea that if you're asymptomatic, you can't spread it?
I don't quote social media very frequently, but I think I will now. Natalie Dean was the author of a study that was like that week before the Christmas holiday. That might have been in JAMA, but I follow her on Twitter. She's an epidemiologist at the University of Florida. I think her studies showed in households, you could look her up on Twitter. I think her studies showed that you were less likely to spread it in households if you were asymptomatic, but no spread is not the message. And she put out several rather emphatic tweets about that was being misinterpreted. Symptomatic people spread it more, asymptomatic people spread it less, but not zero. There's no zeros anywhere there. And it was a sub-analysis of her data. So that's always suspicious when you get into much smaller groups of people.
You bet. All right, Jill, one more question.
Joanne says that she's hearing that healthcare people are opting out of the vaccine. Is that true, and why?
You know, that's a great question.
Yeah.
And let's just answer it head on. We have an uptake rate of about 70%.
Yep.
So about 30% of people, some of whom are, in fact, people who are vaccine hesitant and want to see how it goes. Bob Page, our CEO, had forwarded a document that came from Vizient, a big consortium of healthcare systems around the United States. And I think there are 20 or 30 responses from different leaders around the country and multiple different health systems. And they all were saying the same thing. The range of uptake is between 50 and 80% in healthcare systems. And the number one reason is just people wanting to see how the folks who initially got it do. And then some people are saying as they've watched others get it, they're beginning to want to go get it. And so this is my response to this. It comes from Lin-Manuel's Hamilton. Do not throw away your shot, because this is incredibly important. This is how we win the game. This is how we win a pandemic. And when the call to arms comes to you and you say, not me, not yet, what it means is you're saying to the coronavirus, step in front, go ahead. So the choice is one of two. You can take your call to arms, don't throw away your shot, and begin to help us beat coronavirus, or say, Corona, go ahead, take a step in front of me. Come for me, come for the other ones I know and love. That's the difference, and that's the decision you have to make. Let's turn first to Angela. Final thoughts for today.
Yeah, I think there's different types of vaccine hesitancy out there. We have some healthcare workers who are truly vaccine hesitant for many different types of vaccines, but we have some who are just a little bit worried and are a little bit on the fence. And for those folks, I hope that you have a trusted person that you can talk to and ask the questions that you have, so that you hopefully will gain some comfort level in accepting the vaccine. Our vaccine rates are around 70% too at Children's Mercy, and I would love to see it go even higher.
Exactly. Thank you. And thanks for being a part of the program today. And thanks again for the great work Children has done in our community, helping keep schools safe to keep our community safe. Well done. Dr. Alt.
Well, I've heard Dr. Myers give talks on that topic before, so I was interested to hear what she had to say. But I think I think the 70% you would find for a lot of vaccines, not just in physicians, but in parents and adults who are getting vaccinated. And then there's about a 10 or 20% group of people that are vaccine hesitant. And so, yes, as more people get vaccinated, as more healthcare workers, get vaccinated and talk about how minimal their symptoms were and how relieved they are to be vaccinated, I think that will certainly get us up to the 80 or 90% uptake in healthcare workers.
And where we need to be for the community in general, Hawkeye.
Yeah, I'd just like to thank our guests so much, our pediatrics expert and our vaccine and pregnancy expert. Thank you very much. I think all of the points were very salient and very important, and we touched on a lot of different subjects today, from schools to vaccines to the multisystem inflammatory syndrome in children. All of those things, certainly for the vaccines, that's an important thing. As now the Moderna and Pfizer companies have been ramping up production, as there are more and better systems and protocols in place for getting those vaccines that are currently used into the arms of the people, there will be more supply because the demand is so high right now. There'll be more supply for increased and starting the vaccination on the general public, and we will certainly be ready when that happens. Hopefully it will happen sooner rather than later. I think that time frame can shift a little bit, but certainly we will be ready to get that into the arms of the general public when we can.
Yeah, it is just so important. Hey, tomorrow we're back with Dr. Michael Rippey, a sports neurologist. I know Dr. Rippey very well. He does a great job in the world of post-concussion syndrome and other things. He is starting to see some long haulers with a brain fog and chronic headaches since they've had COVID-19. Dr. Rippey is going to talk with us about how he advises these patients and to let us know what he's seeing. He recently got his COVID-19 shot as well, and so we're going to be talking to him about how it's felt to be vaccinated. I think this is a really important topic. We're seeing more and more about brain fog emerging both around the time of getting COVID-19 and then even weeks later. So it'll really be an important conversation to have. Hey, New Year's holds promise, and that's why we're celebrating the first baby born here at KU. That celebration is a cultural mainstay that dates back as far as ancient Greece. We want to celebrate our first baby born at the health system. Okay, now I am not going to say this name right, and so mom and family, I apologize for this. I think it's Gisley? I'm not sure. I apologize. She was born at 3:40 a.m. My wife's an obstetrician. She's going to hate me for not being able to say that name correctly. As a male, 6 pounds, 9 ounces. Mom is Maria, and she's from my hometown of Independence, Missouri, and featuring some fine Chiefs gear out there. We love it. Congratulations to you and your family. Hey, another cultural mainstay is making a New Year's resolution. I want one of those to be for you to take command of your health. That starts with making and keeping your doctor's appointments and annual screenings, especially cancer screenings. In just a moment, you'll be seeing Dr. Jamie Wagner, who's been on our program before. She's going to share the impact of COVID-19 on cancer diagnosis. We don't want to give COVID-19 the power. How do we keep the power? You got to play offense, you got to play defense. Our defense, now that it's game on, defense are the rules of infection control. And you've heard in this program how those can keep you safe, whether you're at home, you're in an Uber ride, you're in a school, you're at work, you're right here in the health system, where we know that the rules of infection control have protected our staff, even though we've taken care of nearly 2,000 patients now with COVID. So when you think about that number, and you think about the focus and the concentration of all those patients, remember, you can stay safe by following the rules of infection control. And tomorrow, Hawkeye, I got some cool masks for Christmas. I'm going to start bringing a few masks in. I think we ought to show some of the cool masks we've got. What do you think?
Yeah,
let's do it.
Just the regular surgical mask.
I know, we've got some really cool stuff. We're going to start showing off our cool masks because we don't want you to think it's time to stop masking. Keep your masks on. And then let's go get your shot on. Don't throw away your opportunity. This is your call to arms to help keep us all safe. We all want to be back to normal. It's going to hurt my heart to look at Arrowhead Stadium in the middle of the playoffs and not see 80,000 people screaming for the Chiefs. It'll hurt my heart when we can't see 40,000 people at the K welcoming back baseball. But we can do those things soon enough. But it takes us following the rules, getting our shots, and making sure we take care of each other. And that way, we can make sure that COVID-19, that it loses this game. So we'll be back tomorrow. But first, let's hear some really important words of advice from Jamie Wagner.
We are seeing about a 50% decrease in the number of diagnoses of breast cancer. in the country. Then what that translates to is by the time we're finding something, unfortunately, it is probably a more advanced stage than where it would have been had it been found on that screening mammogram. It's really because, as a result of COVID, us shutting down mammography for some time, as well as now that we are open, people still having a fear of coming in. Screening mammography improved survival by almost 40%. So that right there tells you that screening mammography, it does its job. You are the best self-advocate, and part of that is knowing your body. We look more on doing breast self-awareness. The old school breast self-exams where we used to have those shower cards and it had to be done the same way every month. It actually has shown that it doesn't improve identification, but just knowing your body, knowing what's normal for you, even if you feel like you've got a lumpy, bumpy breast, if something is new, if you are comfortable with your body, you'll identify that. We need to set new anniversaries. We need to set new mammography parties. Whatever it was for you, waiting that year until March or July comes back around, we know that that 1 year could make a difference. Screening saves lives, and it doesn't matter what kind of cancer it is. Whether it is lung, prostate, colorectal, all across the board, screening has been shown to improve outcomes for cancer survival.